All right, so this is the last week for the therapeutic interventions topic. And so this week's topic is dry needling. So we will start with the overview here. The kind of the premise is what is dry needling, or how is it different from acupuncture? We'll get into some of the details about the physiological effects of dry needling and how they happen at the local level, at the regional level. So the quarter that it's being applied to, whether that's the lower left, lower right, upper left, upper right, as well as some of the systemic effects and how it affects the body as a whole. We'll get into some of the technical variations and different applications that clinicians are using to kind of refine their dry needling practice. And then lastly, we'll talk about treatment timing. So for the dry needling versus acupuncture comparison, it really boils down to kind of the theory behind it or the approach behind it, and what it is that we're targeting, how we're applying these different needle applications. So for dry needling, this is a Western medicine practice. This is following a Western medical kind of more holistic approach where we're looking at, okay, there's a pathology and we're going to treat the pathology. Whereas acupuncture, there's a more traditional Chinese medicine history to it. And this has been around for thousands of years, where they are actually treating what's called the meridians, or the energy flow, and the qi, so the actual energy in the body itself. So whereas the dry needling approach is to target these myofascial trigger points, the Chinese or traditional Chinese approach is to target the specific meridians and the qi. So depending on what it is that you're looking for, you're gonna either palpate the muscle and look for these taut bands or painful areas within the muscle. Whereas the acupuncture approach, you're actually trying to find some kind of a level of this energy flow that is associated with whatever the symptomology is. And that can include a much more broad category or array of symptoms. Things like anxiety, for example, can be treated with acupuncture, whereas dry needling is specifically targeting these myofascial trigger points. So at the local level, the effects are immediate. And so as soon as you put that needle in, you're going to see these effects happen. So you get mechanical stress, you're actually causing damage to the muscle and the skin. And depending on how deep you're going, you could potentially interrupt some of the nerve these smaller nerves that are integrated within the muscle and the smaller blood vessels. But then you're also going to cause some of these inflammatory responses. So you're going to see this kind of inflammatory cascade where we cause some satellite cells to arrive and repair or replace the damaged cells. So if you break down some muscle cell, then you're going to get satellite cells to replace them that will eventually adapt into healthy muscle cells again. You're going to get some release of some pro or pain inducing substances, such as cytokines, substance P, things along those lines. You will also get the activation of the alpha beta, alpha delta, and C nerve fibers. So that's going to cause a pain signal to happen. And you obviously will feel that immediately. As soon as you insert that needle, you're going to feel a brief moment of pain. Some of the regional or segmental effects take a little bit longer to happen. Obviously, the signal has to be transferred or transmitted up the chain into the spinal cord, specifically into the dorsal root. So you see you cause this afferent stimulus. You apply the needle, and the signal gets transmitted up into the dorsal root, the spinal cord, so that is actually what causes the kind of twitch response that a lot of clinicians are looking for, where you get this contraction or this jump in the muscle, and the athletes will oftentimes kind of freak out, and they don't necessarily know what's causing that, but they'll feel their muscle twitch and jump, and they will have a quick relaxation after that. But that's caused by a signal that's being sent through the spinal cord level. You will also get the release of opioids and monoamines. And so these are kind of pain modulating hormones. And so these can be released at the level of the spinal cord, don't necessarily need to reach the brain. So you have presynaptic and postsynaptic neurotransmitters that are going to modulate pain. And so depending on what the specific hormone or neurotransmitter that you're looking at, these are going to happen at before or after the level of the spinal cord. Those effects will not be as slow as the systemic effects, which will take even a little bit longer. And you will start to see the stimulation of the HPA axis, the hypothalamic pituitary adrenal axis. And so a lot of what this is a much slower hormonal response. And so whereas the neurotransmitters are being transferred pretty quickly, not necessarily instantaneous like the local effects, but these are going to be a lot slower because you're actually having to send the signal all the way up to the brain, which is then sending a signal back down to wherever you're inserting that needle. But basically what the stimulation of the HPA axis is your body's way of kind of managing stress. And so you get this release of or cascade of it, and it's kind of a domino effect of hormones and hormone releasing kind of communicatory or communicating variables that are kind of being sent through different structures in the brain that eventually will lead to the release of cortisol, which is then going to kind of cause a negative feedback loop that should cause a decrease in stress and a decrease in pain. Some of the technical variations, so there's a lot of them here, and these will depend on the clinician and also depend on what the actual level of the pathology is. So if you're trying to do a little bit, let's say, for example, the image on the right, are you trying to do a really deep application where the needle is actually reaching the level of the muscle? Or are you going to do a more superficial treatment where you're only crossing through the level of the skin and some of the superficial or subcutaneous tissue? So probably the most common one that I see applied is static, where you insert the needle and you just let them sit for some extended period of time. Somewhere, I think most clinicians tend to do like 5 to 10 minutes. Although in my course that I took through structure and function, I was taught that the longer that you leave these in, the more likely it is, or the stronger the signal is for some of these segmental and systemic responses. If you just put it in and you're just interested in the local responses, then you can put it in and then take it out right away. So if you want to get some of these more segmental responses, then you can leave it in for somewhere between 5 and 10 minutes. But if you want the systemic, the longer you leave it in, the better. And from what I remember from my course, somewhere around 30 minutes is an effective treatment window. There is then pistoning. So static, you just put it in and leave it there. Pistoning is a much more mechanical approach where you're actually causing a lot more damage to the tissue. So if you have your tissue is here, instead of just putting the needle in and leaving it, you're actually taking it out, putting it back in, taking it out, putting it back in, and you're finding these different directions or angles where you're kind of changing up and down, left, right, in and out, and you're trying to find or you're trying to cause a lot more of this kind of microcirculation where you're causing more inflammation, more signaling, and you get a stronger inflammatory response that should create more of a healing response. That tends to be really good for any kind of adhesions or tightness where you're really trying to target the mechanical symptoms of the problem. So if they have a limitation with tightness or range of motion, pistoning tends to be pretty good with this. If they had some kind of a scar tissue buildup from a previous injury, pistoning is what I tend to use more. I just find that you get much more mechanical benefit by doing pistoning. I also do a little bit more with winding, and the research is pretty well documented that winding works, especially in the unidirectional method. But the pistoning is the strongest mechanical. According to the literature that I've seen, the pistoning has the strongest effect on the mechanical symptoms. This is followed then by the unidirectional winding. So winding is basically you put the needle in and then you twist it to the tissue that is surrounding the needle will then grab onto the needle. And if you twist it, you will wrap it up and you kind of create this little coil. And so you're creating this stretching effect within the tissue that you're grabbing with the needle. Some needles are stickier and can grab more tissue. Some are a little bit more smooth. and then they won't grab as much. So that can be kind of a tricky thing if you're trying to create the winding where you want a little bit more grab in that needle. The like I said, the unidirectional winding, so you put it in and you just twitch, or you just twist it one direction, whether that's clockwise or counterclockwise. You follow that one direction until you get the tension on the tissue, and then you will release it, or you will pull out to create this kind of tenting effect. Or the bidirectional is kind of like a pivot, so you swivel it forward and back, forward and back, forward and back. And so that one still has more effect than just static, but it has less of a mechanical effect than the unidirectional winding. The tenting is where you're actually taking, once you have the tissue grabbing, so the tissue surrounds here, and instead of twisting to create the tension, you're actually pulling up, where the tissue now kind of arches and bows and creates this little peak where the skin or the superficial tissues are now tenting over the needle. The literature for that is not as strong as the unidirectional or the pistoning for mechanical, but it can have some strong effects for the pain response. Similarly, the electrical stimulation approach, so once you put these static needles in, you let them sit, you can apply electrical stimulation to create twitches in the muscle, or you can create just a strong sensation within any kind of a non-contractile tissue, such as a tendon. Depending on who you ask, there's some contractile tissue within the tendon, but for the most part, tendons are non-contractile tissue, and you're getting more of a sensory stimulus through the electrical stimulation than you are true contraction. So when you put electrical stimulation on a muscle similar to like a Mark Pro or an H-wave unit, you're creating this electrical activation of the muscle, where the muscle gets this really short contraction where it's kind of like a twitch, and you will see the muscle twitch as you crank up the intensity of the electrical stimulation. Now, depending on the frequency that you have it at, you will either see these intermittent twitches, or if you want it at a faster rate, then you can create a little bit of localized fatigue by creating these faster twitches. So depending on what your target is or what your goal is of the treatment, if you're trying to relax a specific muscle to then get other muscles to pick up the slack. Say, for example, somebody's in a rehab and they have a lot of compensation in, let's say, the hamstrings, and they're having trouble activating the glutes. You can pre-fatigue the hamstrings and then go into rehab, and then you're going to have much better or much easier time recruiting the glutes because the hamstrings are already pre-fatigued. So that's one strategy you can use with that. Another is just for the hormonal response. If you're trying to get those systemic effects, where you're trying to, you're creating this increased sensation that is happening over a prolonged period of time, and then you're going to get a lot more hormonal or opioid release. The periosteal pecking is used more for bone and connective tissue. So if you have somebody with an articular issue or pathology where they have maybe osteoarthritis, or maybe it's some kind of an osteochondral defect, or if they may have just a little bit of, let's say, what's the word I'm looking for here? Wow, I am, let's say like MTSS, medial tibial stress syndrome, where they have like a quote unquote shin splints. If you're trying to strengthen the bone or the connective tissue, the periosteal pecking can be a more effective approach. The idea here is that you're either scratching the surface of the bone, or you're tapping and you're creating mechanotransduction through those tissues as opposed to the more superficial tissues. So obviously, if you're trying to do that, you have to know that you are touching the bone, and you have to reach that kind of solid backing with the full depth of the needle. If you're just at the level of subcutaneous tissue and you're trying to do periosteal pecking, you're never going to get the effect that you're trying to reach. So for this, it's kind of a weird sensation. Most athletes are like, wait, what is that? I don't like it. But if you explain to them, I'm going to scratch your bone and this is what it's going to feel like, then they can settle into the treatment a little bit more. And there's pretty good evidence to back the effects of periosteal pecking for things like osteoarthritis. There's another one that I saw for, I think it was lateral femoral condyle. Anybody that was having kind of lateral knee pain from maybe either chronic running or some kind of an overuse or a anatomical defect, it was effective to kind of fortify that lateral femoral condyle. So there's a wide array of uses here, but you have to know what it is that you're targeting. Then it goes to superficial and deep. So again, this is the image on the right, and the argument here is basically, do you need to reach the level of the muscle or the contractile tissue in order to have the effects take place of the treatment? And that depends on the goal of your treatment. If you're trying to create this localized twitch response, then yes, you definitely need to reach the level of the muscle in order to hit the end plate and then increase the likelihood of that muscle contraction or the twitch. If you are just trying to manipulate pain, you don't necessarily need to go to the level of the muscle. And so especially if somebody's really sensitive or has maybe fear or apprehension with the twitch response, you can get pain manipulation or modulation just by doing a more superficial approach. So depending on what it is that you're trying to target, and depending on who your athlete is and what their experience or perceptions of pain are, you might want to consider either more superficial or more deep penetration. Similarly with that, you can change the angle of your application. So you can either, if this is my flat tissue here, you can go perpendicular. That's the most common approach, is you're just going straight into the tissue. But you can also change at an angle. You can go a little bit more shallow, and you can create instead of creating kind of vertical depth in the penetration, you can create more longitudinal penetration, and that can create a little bit more blood flow depending on the tissue. So for example, the patellar tendon might only be 1 finger deep, but if you go longitudinally, now I can create a tunnel from my needle that is the length of the tendon, and that's going to have a lot more cross-sectional area where we're creating this inflammatory response, and we're going to get a little bit more mechanotransduction from that treatment, as opposed to if we would just go in perpendicularly. So depending on the tissue that you're working with, consider the angle of the application. Treatment timing. The most common concern that I see here is if it's the first treatment or if they're a regular and they know their response. Most clinicians are not going to do like the first time they're applying this dry needling approach with an athlete. They're not going to do it like the day before practice or the day before a game. A lot of clinicians are fearful and they don't want to create some kind of an issue, and so they'll tend to schedule it like the day before an off day. This has been kind of debunked, and a lot of clinicians are like, my athletes never get sore from this treatment. Like, why would I wait for them to give a day off? And I've even seen some clinicians that are as aggressive as doing it in the middle of a game. One was a hockey athletic trainer who, after the first period, some kind of an ankle contusion, I believe. I don't know if it was from a puck or a stick. I don't remember the exact cause of the injury, but there was some kind of a big ankle swelling. They applied dry needling in the locker room in between first and second period, and then the athlete went back into play. So depending on the sport and the context, you could consider that pre-game or pre-practice. And you could have that as again, with rehab specific cases, maybe you want to do as a pre-fatigue for that muscle, or maybe you want to do it as an activation to kind of build that mind muscle connection so that they can better focus on creating contraction, especially with like something like an ACL. Maybe if you can activate the quads in like the athletic training room, then you go into the gym or the more rehab focus, and they're better able to connect with that muscle that they're trying to engage with. It would just be basically a biofeedback pre-rehab. So that would be one option. And then post, you would be targeting more of those longer lasting effects, either the inflammatory pathway of the local or those longer lasting duration of the opioid release or the hormonal response. So if you're trying to get that hormonal response, probably better to do it after, because it's going to be a 30-minute treatment, as opposed to if you're doing it in the middle of the game, you're probably just going for local treatment, and you're just getting those needles in and out because you don't have enough time to do the longer treatments. Game versus practice. Again, maybe you have to consider, if it's their first time, you don't want to do it the day before a game and then have them show up and complain and say my pain got worse, or I'm so sore from that treatment that I can't play in the game. That's a good way to piss your coaches off. But for the most part, if you know what you're doing, as long as you're considering, okay, is this just going to be a static treatment in which there's really low risk of having soreness, or am I going in there and I'm just hammering away with a pistoning technique, which they're more likely to have? Granted, you get the benefit of the mechanical effect, but you're going to have more likelihood of soreness after that treatment. So considering the treatment and the application, you can time it effectively. For the literature review for this week, so Structure and Function is who I did my dry needling certification through, and their course was pretty good, but I think that the educational content they put out is a lot better, and specifically the online material that they have. So you can do either their in-person course to get access to their content, which I think is really good. You get that for life, and I refer back to it all the time. But then also online, they have on their website an educational community where they publish either blog posts or podcasts or things that they found in terms of literature. There's a wealth of resources in this website page. So check that out if you're looking for educational content surrounding dry needling. The NIH has a publication called Dry Needling, a literature review with implications for clinical practice. This is a really good overview, and it talks about just the gist of dry needling and when you should or should not do it. So it's a pretty good introduction, and it's backed obviously because it's an NIH published review, that it's a little bit more evidence-based if you're looking for that. And then lastly, there's a chiropractic clinic that I'd never heard of before, but they had a blog post called 4 Different Types of Dry Needling. And in this blog post, they break down, I believe it was superficial, deep, electrical stim, and maybe pistoning. I can't remember the fourth one, but they do a really good job of explaining some of those different applications and techniques that I was discussing earlier. So if you're looking for a little bit more depth and you want to read more about those, that's a good place that you can go check out the different techniques. For the media side of things this week, Structure and Function also has a YouTube channel, which I just discovered. I didn't know that was a thing before. So while I was putting this presentation together, I found that YouTube channel. So that's a really good source for educational content. There's podcasts, there's different guests, there's clinicians. The director, I would think she's the founder, Sue Falsone, but probably butchering that name, but I think that's how they said it on the podcast. She is the one who actually puts together all of the educational content, and she is a genius when it comes to dry needling, but she's also been an experienced athletic trainer and physical therapist, strength coach for professional teams, specifically within baseball. She had a really long tenure with, I believe, the LA Dodgers. I could be wrong on the team, but she worked in pro sports for quite a long time. So prior to starting this company, she gained tons of knowledge and experience that she then shares on this platform. So especially being on YouTube and having it be free, highly suggest any clinician that wants to learn more about dry needling to check out their page. Cleveland Clinic has a really short video that breaks down the difference between dry needling and acupuncture, which is essentially highlighting the things that I already did. Western medicine versus traditional Chinese medicine, the energy flow versus the trigger point targeting. And there's a few other subtleties in terms of like needle size and I think the treatment duration, so stuff like that. But it breaks down the difference. And if you're curious about the history between those two, the Cleveland Clinic video is, I think it's only like 2 minutes long, but it does a good job of differentiating those two. The last one I've got on here is the Institute of Clinical Excellence podcast. This podcast I found it on Spotify. I'm sure it's everywhere because ICE does a really good job of publishing all of their media. So I'm sure you can find it elsewhere, whether that's on YouTube or Apple Podcasts. But I listen to it on Spotify. It's a really good job. They do a good job of explaining the more practical approach where the clinicians talk about their experience and their kind of learned hands-on approach and what they found to be effective and what they've found not to be effective, things that they're taught, things that they've kind of gone away from, things along those lines. So if you're looking for the more practical side of dry needling, check out that podcast. Then for the publication review. So this week's paper was a literature review, and it was titled Physiological Effects of Dry Needling. So this was published, I can't remember the year off the top of my head. 2013, it looks like. So it's been a while by now, roughly 10 years. And now we probably understand more of the physiology behind dry needling, but I think it's important to kind of keep in mind when you're applying these different things, how young the science of dry needling is, especially when we compare the understanding that we have of acupuncture, and a lot of the literature that people use to justify dry needling is literally acupuncture research. And so that's an important consideration because they're not quite the same. So in terms of the application, we need to consider the pathways and the physiology, the pain experience of dry needling as opposed to acupuncture. So this literature review, they break down individually, and they go through the science of starting with a general overview of pain pathways and how pain is actually experienced. Then they get into the pain modulation approach and how there's different ways to interfere or intervene with people's experience of pain. And then lastly, or they'll get into the perception of pain and how people's experience with pain shapes or warps their perception of pain. And then lastly, they talk about the physiology of myofascial trigger points and how we can target them. Then they go into a critical analysis where they break down. So in the literature review, they just discuss the existing literature and the science behind it. So they talk about what evidence is out there currently, and then they break down that quality of evidence in the end and in the discussion to give clinicians a more informed approach when they're talking about dry needling and when they're discussing this treatment with the athletes that they work with. So what they found was the methodological variation between clinicians makes it really difficult to study this approach. So if we're trying to be objective about dry needling effects, then how can we compare when somebody's doing a perpendicular application versus a longitudinal application? How can we compare when somebody's doing a static treatment versus a pistoning treatment? And so it's really tough to have high quality evidence. This paper kind of harped on it and said the existing literature is mostly acupuncture, and even the stuff that does exist for dry needling is pretty sparse and it's pretty poor because it doesn't necessarily talk about the technical application. Things that they were considering included like tissue depth, treatment time, the duration that they're leaving the needles in, the frequency, how often are you doing these different treatments, as well as some of the like pain markers and the physiological adaptations. Are we getting increased blood flow, stuff like that? So the methodology of dry needling in and of itself makes it really hard to research. As for the mechanisms of the treatment and how we understand them, it's really complex, and it's not as simple as we make it seem when we're explaining the treatment to the athletes that we work with. Oh yeah, we just put the needle in and cause a little twitch and then your pain goes away. But in reality, like, we don't really understand in depth why that happens or how it's happening. And so some of the things that this paper is highlighting is the difference between peripheral pain and central pain, and how the different neural networks are integrating with one another to communicate the pain signal. So talking about specifically like the gate control theory, and how we can use faster neural communication to then block slower pain signals that are arriving via the C nerve fibers. So we're stimulating the alpha beta neurons, and we're trying to beat the pain signal that's traveling via the C nerves that are non-myelinated. So the other thing that it discusses is the physiological versus psychological experience and how intertwined they are. So for example, somebody's perception of, oh, I think this treatment is going to help me, A lot of the effects of the masking of pain happen from placebo, but those exact placebo responses are happening at the same level through the same brain structures as the proposed mechanism for dry needling. So, for example, the HPA axis that we discussed earlier, that is being stimulated by dry needling. We know for a fact that it is. But also, the HPA axis can be stimulated by somebody who thinks that the treatment's going to work for them. So, the release of the cortisol is happening, which then goes on to have a pain modifying effect. It's unclear if that's happening due to the placebo or due to the treatment, or if it's both, or if it's magnified. How the interaction between the physiology and the psychology, how that's influencing the overall pain experience and perception. A lot of the, I said this earlier, but a lot of the clinical evidence exists from acupuncture, and this is problematic when we're looking at things like the physiology between or behind how dry needling works. So when we're looking at things like growth factors, or we're looking at things like the inflammatory response, we don't necessarily know how much of that inflammatory response is happening when we do dry needling, because most of it we're just extrapolating from the acupuncture literature. So that is definitely something that needs to be, or the authors in this paper say that it needs to be differentiated, and we need dry needling specific research. The last point that the authors were making was that it was contraindicated for patients with central sensitization. So effectively, the chronic pain experience that some of these patients or people are dealing with, they have chronic pain, which then alters their entire experience around pain. So not only does it shape the way that they're anticipating pain, but it also actually, I just found this out while I was reading this paper, but it actually manipulates their ability to cope with pain and the brain's response to this pain modulating variable. So the ability to release opioids in order to manipulate. So, for example, serotonin or dopamine are both largely responsible for the pain response, or for modulating the pain response. In chronic pain, people have defective brain activity and they don't release serotonin and dopamine how they should in order to cope with that pain. So they end up experiencing more pain than somebody with a functioning perception of pain. So that's kind of an interesting consideration. And when they talk about treating these individuals with central sensitization, they actually feel more pain. And when you induce pain because of the dry needling, you insert that needle, you cause peripheral pain, but then also you're creating kind of this trauma response where you get an ineffective, you don't necessarily get the same inflammatory cascade that you would typically see. You don't see this hormonal or neurotransmitter response. And so you end up getting increased pain without the tissue healing as well. This literature isn't quite clear. And so they had some disagreement. Like some clinicians were saying, yes, you need to continue to treat it for things like fibromyalgia. But for people just with chronic pain, but without an actual diagnosable condition, this was contraindicated according to this paper. So the last slide I have here is just to show the different or the complexity that the authors were talking about. And so like they're not saying that it's so complex and we need to do a better job understanding it. We understand it fairly well, but when we're talking about all of these different variables happening at once, which of these variables is most responsible for the effects that we see? Is it the increase in blood flow? Is it the decreased SEA with the localized switch response? Is it the segmental inhibition where you're getting the gate control, where you're blocking that pain signal at the level of the spinal cord? We don't really know which of these is happening, or if all of them are happening, or how they interact with one another. So the pain experience itself is largely not understood. And this is a big reason why, like, there's so many different variables at play. And this isn't even considering the different technical applications of the needles. This is just saying needle insertion, and that leads to the local microtrauma, the mechanical stimulation or the mechanotransduction, and the activation of the different nerve fibers, which then leads to the hormonal and neurotransmitter effects, the opioid effects via the ascending and descending pathways, these central versus peripheral neural networks. And then ultimately arriving at the level of the brain where they're perceiving this pain experience. So it's a really complex process, and it's not as easy as just saying, "Oh, just put a needle in that tight muscle, and it's going to feel better." So, in summary, there's a difference between dry needling and acupuncture, and even though those differences are subtle, they need to be better understood within the literature. Um, Specifically, the dry needling approach being a Western medicine process and targeting myofascial trigger points, we need to do a better job of understanding the myofascial trigger points physiology, and then the pain behind it and how the dry needling treatment is influencing the pain and the physiology, how it's going to help healing. There are different effects happening at the local, regional, or segmental and systemic levels. And depending on what you're targeting, you can adjust your treatment accordingly. There are different technical variations that you can use to either tease out the more local effects. So you can do the more static and you can do a shorter duration. Or if you want those systemic effects, you might want to include something like electrical stimulation and you want to leave it in a little bit longer. And then lastly, the treatment timing. So kind of planning around things like games or off days and the first time experience versus somebody who does it regularly. Although largely you can do it pretty confidently and you don't have to worry about them missing the next day. But that's a risk that you need to consider when you're choosing the timing of doing these treatments. Next meeting will be the new topic, which is general medicine. And we'll move into some things like travel complications, common illnesses, COVID, things along those lines. So, hope to see you all there.